Hello, everyone. We're going to jump into chapter 9 today. It is a kind of a long chapter with a lot of material that's really important. So you definitely want to make sure that you're giving it plenty of time to be familiar with all of the material. All right, let's jump right into the chapter. You're going to hear the dogs behind me. They're not happy about some things. Okay. Surgical pharmacology and anesthesia. We're going to cover all of that. So after studying this chapter, you will be able to assess the action, uses, and modes of administration of drugs and anesthetic agents used in the care of the surgical patient. Also, you'll be able to convert equivalents from one system to another and accurately identify and mix and measure for patient use. Recognize general terminology and abbreviations associated with pharmacology and anesthesia. Demonstrate safe practice in transferring drugs and solutions from the non-sterile area to the sterile field, and demonstrate the procedure for identifying a drug or solution on the sterile field. And the lab instructors are aware that you're learning this, so you should find that they are starting to teach the practical application in the lab setting. So just be looking for that to be taught in the lab. You'll also be able to recognize the side effects and contraindications for the use of drugs and anesthetic agents, interpret the factors that influence anesthesia selection for individual patients, and compare and contrast the roles of the surgical technologist and the circulator during the administration of anesthesia. So what is pharmacology? It is the study of medications, their actions, including their origins, where they came from, their properties, how they act, and the uses that they're prescribed for. A drug, on the other hand, is a substance used for the diagnosis, treatment, cure, mitigation, or prevention of a disease or condition. So as far as the properties of these pharmacologic agents, we need you to understand the concepts that guide the medication use and the dosing. We're going to talk about the properties of these pharmacologic agents, including both pharmacokinetics and pharmacodynamics. Now, we're going to go ahead and jump over to the book, because here's a bunch of drug sources. So drugs are all derived from a either a natural source or a laboratory synthetic. And so most have originated from a plant or animal or mineral based and then synthesized in a lab for more larger distribution. But from plants, we've seen things like morphine derived from that, digitalis. Also, from animals, we see things, heparin, thrombin are some examples of that. Minerals will get things like calcium, magnesium. Those are derived from the earth and from the mineral salts in the earth. Now, laboratory synthesis, these drugs are created in a laboratory based off of other medications as well. So there may be some combinations or some adjustment to certain things that are made based on the actions that they provide. So we're looking at Demerol, aminoglycosides, antibiotics as well. And those are semi-synthetic drugs because they take the natural substance that provides that benefit, and then they chemically alter them to either address slightly different pathogens than the natural could, or kind of alter it in a way that will ramp it up a little bit. And then there's biotechnology. And this is from genetic engineering or recombinant DNA, that they take that and then they introduce the foreign DNA into it, and then it allows them to find the vaccines that will inhibit specific pathogens. An example of that is Hep B vaccine, or almost all vaccines in that manner. Okay. And here is more of that. Just go through that in your book, make sure that you're familiar with that. Pharmacokinetics. So this is talking about the metabolic processing of a drug within the body. So it means how does it metabolize? How is it absorbed? How is it distributed? And then the biotransformation, and then how is it excreted? So the absorption phase, so that those are the 4 phases of pharmacokinetics. And so the absorption phase, this occurs at the site of the administration. So whether it is taken by mouth, whether it is injected through an IV or into a muscle, whatever that site is, this is where absorption happens. And the passive transport occurs because it's going from an area of higher concentration to an area of lower concentration. So there's no energy needed. The concentration is transporting that material across the tissues. And most drugs are transported in that way. The rate of that absorption is going to affect the final action. So it's going to affect how the drug interacts with the tissues, what that final result is, and if that needs to be adjusted. So absorption is a major part of the pharmacokinetics. Now, with local use of medications, many times they're absorbed too quickly. So epinephrine may be added to some of the solutions because it will slow down that absorption rate, because it causes that vasoconstriction in the area. So it will slow down the rate of absorption at the local site. And you'll see this a lot with stitches. You know, anytime stitches are going to be done, they may do epinephrine. This is in an awake patient, but you may also see it used in local anesthetics. So just know that epinephrine is something that is added to prolong that absorption rate. And then the distribution, so that's the transport of the medication once it's in the body, in the circulatory system. And so this is how it's distributed. It's going to be transported to all the parts of the body, and it's definitely affected by that absorption rate and then the cardiovascular function. And what that means is that depending on how the heart is functioning and pumping blood out into the arterial system that then becomes the venous system, that function is going to greatly affect how well a medication is distributed. Because if someone's cardiac output is low, the distribution is going to be low, because then the circulation is low. So if that distribution needs to be higher, then things may be done to try to improve that circulation. Then the biotransformation. So this is the metabolism of the drug, meaning basically the breakdown of it. And so when a drug is broken down and metabolized, it creates these byproducts called metabolites. And so a lot of times when we're testing for, let's say, a drug screening, we're not testing for the medication, we're testing for the metabolites. So anytime we're testing for things like cocaine or heroin in a drug screen, we're looking for the metabolites of that drug, because it's already been broken down, and now we're looking for the metabolites. So we know then those breakdown products of that medication are only specific to that medication. So that helps you identify that. Excretion. So this is the basically the elimination. So once the effects have continued and through the biotransformation, then they are, and the excretion, we're still getting the effects of it. Know that the kidneys are responsible for the filtration of the drugs from the bloodstream. And so that is why the kidney can take a hit when there's a lot of medications on board to be filtered. The filtration system can also eliminate through the saliva, sweat, and exhalation. So the lungs can eliminate some, saliva and sweat both. And then we also had to take into effect then we're looking at the pharmacodynamics, and this includes things like drug interactions. And this is a really important topic because there's a lot of drug interactions where the drugs interact with each other in different ways. So agonist interaction, this is when two drugs are prescribed together because they either potentiate or enhance the effect of another substance. And so many times you'll see drugs given in combination for that purpose. If it's a synergistic action, this is when they're combined because together they provide a stronger effect. An example of this, I think about respiratory wise. You know, we know of albuterol being kind of the main respiratory inhalation medication, but if it's combined with ipratropium bromide, that provides a stronger effect. Then you can do additive agents, and this alters some aspect of the action of the original agent. And we can think of epinephrine in this way, because if we add epinephrine to anything, it's going to slow the absorption rate. So that is altering some aspect of that original agent that it's added to. Now, an antagonist, that's going to do the opposite of an agonist, which, remember, an agonist is going to enhance the effect of the other substance. An antagonist is going to prevent that from happening. So it's going to bind to the receptor site where that drug was supposed to act on, and it's going to prevent it from binding. And so there it's going to not allow it to provide the effect that it was meant to do. So it will reduce the effect, basically, where an agonist is going to enhance the effect of a substance, an antagonist is going to reduce the effect. Now, timing of interactions, this is meaning the onset means when the medication is going to kick in, basically. Then the peak is when the action is at its strongest. And then the duration is how long that is going to last. So thinking of something like pain medications, you know, morphine is an example. You know, the onset is fairly quick, then it peaks, and then it wears off quickly. So this is, you know, the three things that are taken into account when medications are being decided upon. It's about, you know, how quick do we need this to act, and then how long do we need it to last. And then the selection criteria, we look at the indications. So what is this medication indicated for? Is it indicated for pain? Is it indicated as an antibiotic? Like, what are the indications, and does it meet that criteria? Contraindications, we're looking at what side effects it could cause, or what organ systems it might interact with. So we look at things like if they have chronic kidney disease or liver disease, you know, diabetes. There's a lot of conditions that we take into account when we're looking at choosing a medication. And then, of course, the actions. What is it going to do? And is that what is needed? And the dosing is dependent on, of course, the weight and the gender. And so this is going to all come into account when we're looking at what is available and looking at the demographics of the individual patient. And then classification is important, and a lot of those are named in just the categories. And so they'll be categorized either by their principal action. So an example of that would be all your beta blockers. So that's, you know, a cardiac medication, but it's also used for other things as well. But because it blocks those beta receptors, that is a beta blocker category. If it's an organ and body system affected, so if it's a cardiac drug or a hormone medication, you know, the things that we're looking at, what system they are affecting is going to help classify them. And then the physiological action of the drug. And so this could be, you know, something that, like an antibiotic, that would definitely be a physiological action. It's providing that action in the body. And then the therapeutic action, what is it overall performing? Is it a antidepressant? Is it a stimulator of some sort or a depressant of some sort? And then the goal is for medications is the treatment of the illness or the disease. And so we're looking to prevent medical conditions if possible, or improve them, or just outright treat them. So we look at the effects that a medication can have. So we want that therapeutic effect, and that is the effect that the medication has on the system that it's targeting. So there is always a target cells that a medication will address. Side effects, so these are things that occur within the body that are not necessarily desired, but they're tolerable. And so typical kind of side effects would be headache, nausea, vomiting, diarrhea, constipation, insomnia, things like that. We can tolerate that. But an adverse effect, this is something that is not well tolerated. So that could be as severe as an anaphylactic reaction. And so that is something we have to take into effect. And then, of course, a toxic effect. This is something that actually creates a toxic environment in our body, and that is not desired. So things that have metals in them is an example I think of right off the top of my head. But we're not wanting something that has a toxic effect. Some chemotherapy and radiation can create toxic effect. Tolerance, so this is when we build a tolerance to the medication. Those receptors over time become sensitive to that medication, and so then we need more of that medication to activate those receptors. So that's when we are using medication and you're like, that 800 milligrams of ibuprofen is not getting it anymore and needs something more. And so that tolerance is a normal thing. Addiction is when the physiological need for the medication is predominant here. And so when there is an addiction, the body has become reliant on that effect of the medication. Okay. Let me stop the share. We're just. All right. So there are some different ways that the medication will be administered. Parenteral, so this is anything other than oral, basically. So we're looking at IV administration being the most common. We can also do intramuscular, but the IV is the most common. And we'll look at the other, let me get to the, excuse me, get through the book section here. All right, here are the different types of routes of administration. So of course, enteral is through the intestinal tract, oral, that is also known as PO, and you'll hear NPO, so not by mouth is what that means. And all patients that are coming into the OR are NPO for a minimum of 8 hours. And then rectal is another entry route that where like suppositories placed in the rectum. So other than that, everything is either parenteral or topical. And so we can do it intradermal. So that's where it's placed beneath between the layers of the skin. And an example of that would be your TB skin test. Subcutaneous, that's placed in the fat tissue layer under the skin. Intramuscular, This is within a muscle, so this is like getting a vaccine. IV, of course, is in the vein. Intra-articular, that's placed directly in a joint. Intrathecal, so this is placed in a subarachnoid space. I've got a picture of that. And then intracardiac, this is placed in the heart. And then, of course, topically, here we've got buccal. And so that's like when you get a shot when you're at the dentist, they place it between the teeth and the cheeks. Sublingual, that's under the tongue. Instillation, this is in a hollow cavity. So like the conjunctival fold or in the bladder. And then inhalation, so that's like your gas prior to intubation during anesthesia, or respiratory treatments, that is inhalation. Okay. And then the drug standards. Let's just jump back over to the book. So here we're looking at different standards. There's different committees or associations that are managing the medications. Every state has what's called and the national has a formulary, and this allows us to know what drugs can be prescribed. So you may hear of a drug that is only available in Europe. Well, that means it's not on the United States national formulary yet. So once it's gone through the testing procedures, things will be added to a national pharmacy. Pharmacopoeia of the United States, this is the USP. This is where they're looking at generic names, their source, their properties, all the information. American Hospital Formulary Service Index, Physician's Desk Reference, this is a PDR. Every physician typically has one of these. It's not an official listing, but it does provide all the information that we need on the medications, and they're listed alphabetically. Joint Commission National Patient Safety Goals. This is the where we find those look-alike, sound-alike medications, and officials do not use abbreviation list, and we're going to look at that just briefly. Okay, so drug nomenclature, and that means how they're named, and there's 3 different ways that they're named. And so either by the trade, brand, or proprietary name, and that is going to be assigned by the manufacturer. So I will use a respiratory drug just because they're kind of simple and they're really common. And so you probably heard of albuterol as a inhaler. Well, that is a generic name. That's a non-proprietary name. It is a shortened version of the chemical name. But if we hear of Proventil or Ventolin or ProAir, those are the brand names. So a manufacturer will take albuterol and they will patent a brand name of it. And so, but they're all the same. And then the chemical name is albuterol sulfate. And so that is the chemical composition and that molecular structure. And you can look at table 9.5 for more examples of that. Then controlled substances, we're talking about the classifications now. So controlled substances, they have a really high potential to cause that dependence, so that's addiction. You can look on table 9-6 for more of those. But just looking at controlled substances, there's 5 categories of controlled substances that we have to work within. And you can look at that table and see which ones fit into which category. The higher controlled substance are going to be more regulated than the lower controlled substances. And then prescribed medications. So this is medications that if they're used inappropriately, they could cause harm to the patient. So it's not a drug that we can have over the counter. An example of that is antibiotics, because if they're used inappropriately, then they can have really strong adverse reactions and also strong side effects. And then there's the FDA pregnancy drug category. So in this, it's saying for each medication, what's the risk of it causing harm to a fetus? And class A, there's no risk that has been found. And these are all studied, well studied. B, the studies show that there is no evidence of risk. Class C shows that the benefits outweigh the risk. Class C shows that there is a risk, but again, the benefits may outweigh it. And class X, the risk outweigh the benefits. And class N, it has not been classified by the FDA. So that means that there's not been enough studies done on the medication for it to have a classification. And then we have over-the-counter medications. And so these are medications that are safe for people to administer to themselves or their family without any direction of a physician. So these are, we're talking ibuprofen, Motrin, Tylenol, Benadryl, all those things over the counter that you can self-prescribe. And then alternative medications. So these are medications that, or supplementation, that there's continued studies going on. And it is limited compared to pharmaceutical medications, just because they have a lot of financial backing to provide more studies on those medications. And so as the studies continue to help determine the safety and the effectiveness of these type therapies, there's a very limited understanding within the allopathic world, which is where you're going to be working, of the benefit of things like fish oil and CoQ10 and vitamins, B's and magnesium, potassium, things of that nature. And so just know that patients are going to come in and they may be seeing, a form of provider that is going to prescribe these supplements, and so the surgeons a lot of times will have them discontinue those prior to the procedure because they're not really understanding of their benefit. And then medication orders, the way that they are ordered in the OR, you will hear PRN, and that means as needed. A standing order is something that is written usually in a facility, but it can be per provider. So one surgeon may have a standing order that immediately post-op that every one of his patients receive this set of medications. And so that is easy for the nursing staff to follow because they're not having to ask for orders on every patient. Stat, this is an immediate use. And then verbal, this is when the doctor gives a verbal order to a nurse and will later write the order in the chart, because in a hospital setting, every medication order has to be written in the chart and signed by the physician, but they can give a verbal order and then sign it later. And that is the nurse's responsibility to make sure that's signed, of course. All right, so here's some important calculations we're going to talk about. And this is more of the complicated part of the chapter, is understanding calculations. And you can get your instructors, lab instructors, to help you practice this as well. I've let them know what you're learning in this lecture, but we're going to look at concentration. So concentration is the ratio of the solute to solvent. And what that means is the solute is what you're trying to dissolve, and the solvent is what you're trying to dissolve it in. So an example, a very simple example, is if you're taking salt and you're in your kitchen, you're taking salt, you're going to add it to some warm water and mix it up. Well, the salt is your solute and the solvent is your water. And so as you mix that up, you're saying, what is the ratio of this salt to this water? Is it 1 to 4? Is it 1 to 10? Is it 1 part salt to 10 parts water? So what is that concentration? And so we do that same thing with medications, where we may add a powder to a liquid. So we may add some powdered medication to normal saline, and we're going to do that. The dose is the overall amount of medication that's delivered to the patient. So it might be 2 milligrams of a powder that we're adding to 500 milliliters of saline. And so we've got to adjust that. And then the application, so this is how it's applied in the surgical setting. Is it irrigated directly into the wound? Is it going to be given IV? Is it going to be packed into a wound? What is that? Then the cumulative dose is like the overall amount of medication that the patient received in that dosing. And then the metric conversion, we're going to talk about pounds to kilogram. So with this, we're looking at how many, there's 2.2 pounds to 1 kilogram. So you're going to be having to convert the patient's weight to kilograms because all medications are calculated in the metric system. Okay, so concentration, and that's the first part here, we're converting the solute to the solvent. And so a good example is here we've got a medication, cefotetin, and that we're looking at 1 gram of that, which is 1,000 milligrams of the powdered form, okay? And, or you could also call that I can't remember exactly, cefotetin. And so this is a 1 gram, right? We've got 1 gram, which is 1,000 milligrams, and that's in a powder form. And so we're wanting to give it by a wound irrigation. And so we're using the IV, we're taking 1 gram of that and we're reconstituting, which just means adding water to it to make it more in the liquid form. And so we're going to reconstitute it with 10 milliliters of sodium chloride, which is normal saline. And this is going to make, so 1 gram, remember, is 1,000 milligrams. So it's going to make a total of 1,000 milligrams per 10 milliliters of normal saline. So what we need for the irrigation is we need 2 milligrams per milliliter. So how do we get that? So we add the whole gram of that, which is that 1,000 milligrams, in a 500 milliliter of normal saline. And then we're going to divide both of that by 500 to get the 2 milligrams. So we've got 1,000 milligrams of medication, 500 milliliter of the solvent. We're going to divide both of those by 500, and that gives us 2 milligrams per milliliter. And you can see down here in the bottom, this is the way the equation is written out. And we have means and extremes, and that's a mathematical term, but that means that the B, and so we're doing a cross calculation, and you're gonna calculate means together and extremes together. So you can see here that that's the way we're cross calculating to get that 2 milligram. And then characteristics of a percentage, of course, that we're looking at percentages. And so that, of course, is going to be a fraction of 100. It's always expressed as a whole number with the percent sign following it. You can express it as a decimal just by moving it 2 places to the left so that it's written in the 100th point. There's a table in the book where you can look at the decimal placement just so you're comfortable with that. And then, of course, we're needing to convert temperature. Fahrenheit is what we're familiar with, but in the medical world, you're going to be using Celsius. And so you have to be familiar with that formula. It's also in the book, but that is Fahrenheit -3 times 5/9 is your Celsius. And then if you're having to convert in the other way, it's Celsius times 9/5 plus 32 degrees, or plus 32 gives you Fahrenheit. Everything that you will be using, though, in the OR is in Celsius already. So the monitoring systems are set up on Celsius, but you do need to know how to calculate this just for your testing purposes and for board exam. And monitoring the body temp is really important, and this is something that just extra eyes are always helpful. If it's not in range, if that temperature goes out of range, then the procedure will have to be delayed, or it may even be canceled. We can't operate in a hypothermic situation unless that is a specific desire for that procedure. And there are a few that desires that. And then there are certain medications that are used by anesthesia that can affect that thermal regulating system in the center in the brain. And so then the body's ability to adapt is inhibited. And so we have ways of counteracting that. We have the heating blankets and air blankets, things that will help warm up the body. And we also can pack a body in ice if we're looking at too high of a temperature. And then the units of measure. So we'll look really quickly. Well, actually, you can look at tables 9.9 and 9.10. And this is the metric system for, what we're talking about in, let me get over here real quick. I do want to make sure that I cover everything that you need on that. So here we're talking about, of course, the decimal system, knowing that 1 is 10,000, and 1,000, hundreds, tens, ones, tenths, hundreds, thousands, 10,000s, and 100,000. And then on the metric system of how things are measured. So length is measured in meters, weight is measured in gram, and then volume is measured in liters. So thinking about back to our calculation example, we had the 2 grams or 1 milligram or 1 gram, which equals 1,000 milligrams of the powdered medication. And so that was the weight. Then we were adding it to 500 milliliters of water. And so this is the volume. So here we've got weight is in either kilograms. That's how humans are weighed, is in kilograms. And then grams are or milligrams, and then micrograms. And then volume, we're looking at kiloliters, liters, cubic centimeters, or milliliters. Just know that cc's and mLs are interchangeable as far as the amount of volume they fill. And so when you're looking at a syringe, it may have cc's on one side and mLs on one side. And so just know that it's interchangeable there. And there was all of those abbreviations that we just went over. Now, medication errors have been attributed a lot to some use of abbreviations. And so there is a do not use list. We do want to take a look at that. Here it is. And so Joint Commission, this is their official do not use list. So in this is not going to pertain to you as much, but be able to identify that, like if it's written on the board, you'll know. So in the past, we could write U for unit or IU for international unit. Now it needs to be written out. Q day is now written out as daily. QOD is every other day. If there's a trailing 0, you just write XMG. There's a lack of a leading 0, you just write 0.x, so instead you just write 1 milligram or 0.1 milligram. MS is now written out as morphine sulfate. So you can see things are not abbreviated as much, they're actually written out. Writing the drug's name in full. So when you're labeling your syringe or you're labeling your cup, you're going to write it out completely. You're not going to abbreviate it MS or MSO4 or MGSO4. You're going to write things out so that there are no errors on your shift. So, of course, drug safety is going to be one of the most important things that you're concerned about. You do want to be familiar with pertinent state and federal laws. And more than that, know the policy and procedure of your healthcare facility. Now, we will talk about the 6 rights of medications. And this is them. So this is all covered in the timeout. So you have the 6 rights of medication administration. You have to make sure you have the right patient, and this will be confirmed several times. The right drug, the right dose, the right route of administration, the right time and frequency, and the right documentation, including your labeling. And so these things are confirmed between you and the circulator 3 times before a medication is given to a patient. That is typically at the very beginning, once it's introduced to your table, and then during your count, many times you will you'll also identify that medication, and then at the time it's being administered, and you're then preparing it and handing it to the physician. So that's another time that you're confirming the dose, all of these, the drug, the dose, the route, and all of that. So just know that you're going to be saying that same information several times, but that's the way that we eliminate these drug errors. And then there's different types of container types, and we're going to look at those. Of course, here's the medication identification. So this is the way that you're going to look at. These are called ampules, and so these are glass. You can see it has a little indentation on the neck on both of these, and that's the break point. And so you literally are going to take a just like a 4x4 gauze and hold it in that, and then just bend that forward or back, and it's going to break the top off at that point. These are vials, and so these have a rubber stopcock on the top. Underneath this little red tab is going to be just a little rubber seal, and you'll see that. And then I think that was the last one. And this is the medication label. This is normally how it's labeled. So it'll have a lot number and an expiration number that'll be right along this side. Here's the name, and there's the NDC number. There it tells you how much is in the bottle, 10 mLs. This tells you where it's from. This one is from beef lungs. This tells you that it has 1,000 units per ml. So that is the cumulative dose. And then it tells you how it should be used, where it's packaged. And I think that's the main things you need to know. And then here's the breakdown. Of course, it tells exactly what all is in this container. And then here is a syringe. So there's your needle, there's your Lurlock tube or hub. You'll be able to see medication through this little hub. And then of course, here is your the barrel and the rubber plunger tip, and here's your plunger. And so you're going to be using these on a regular basis, and you'll want to be familiar with the needle and the bevel and the lumen of it. So you want to be aware of where the bevel is at. Is it up or down? This is called the shaft and the hilt, and this is the hub. And of course, then it has a plastic sheath over it. Make sure there's no more pictures we want to look at. We'll look at that a little bit. Okay, so I'm going to show you some steps of how to administer. I've got 2 videos for you to watch on this of how to draw up medication.
Haven't started your holiday shopping yet? There's nothing worse than finding the perfect gift just to realize.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to demonstrate how to withdraw medication from a vial. When withdrawing a medication from a vial, you want to make sure that you're following your employer's latest guidelines and the drug manufacturer's recommendations for withdrawing that medication from a vial. First, what you want to do is gather your supplies. So you want to look at your physician's order and see what medication's ordered. Then get the correct medication in its vial. You'll also want to grab some alcohol prep, a syringe, and the size of syringe that you get depends on how much medication you're giving. So we're giving 2 mLs of medication, so we grabbed a 3 ml syringe. You also need a vial access device that's going to attach to the syringe's needle adapter to actually help you withdraw the medication from the vial. And there's various things you can use to help you withdraw the medication, which we'll go over here in a second. And then you're going to need an extra needle to actually administer the medication, because you're not going to use the original access device that you attached to the syringe that helped you draw up the medication. Then you want to perform hand hygiene. After you've done that, you want to set up the syringe and attach the vial access device to the needle's adapter if needed, because some may already be prepared. Now you can use different vial access devices to withdraw the medication from the vial. One type of device is just a plain needle with that beveled tip. Another type is a blunt tip fill needle, and this can be used to decrease needle sticks during medication prep, or a filter needle can be used. Now, whenever you're withdrawing medication from a glass ampule, you'll always want to use a filter straw, and I actually have a video that you can check out where I demonstrate how to do this. But some medications that need to be reconstituted from their powder form and removed from a vial may need this. But you want to check with your facility's protocols and the drug manufacturer if a filter needle is needed to withdraw the medication from the vial. So we're going to attach a regular needle to the syringe's needle adapter. First, what I'm going to do is I'm going to open up this packaging of the needle, and I'm going to leave it in there. Then I'm going to open up the packaging of the syringe, and one thing about the syringe that you want to remember is that you only want to touch the plunger flange and the barrel. You never want to touch the shaft of the plunger or the end of this tip because you can contaminate your syringe. And now we're going to remove the needle that we used to withdraw the medication from the vial and apply a new needle to actually administer the medication. And this would be the same case for if we use a filter needle or one of those blunt tip fill needles. You would always change that out. Now, why do we want to change this needle out? Why wouldn't we use it to give it to the patient? Well, there's two reasons. One reason is whenever we penetrated the stopper of that vial, it can dull that needle, and that would not feel very good to the patient to get a dull needle if they're getting an injection, let's say. Also, this needle has been inside the medication vial, so on the needle you can have some residue of the medication, and if we go and just inject that into our patient, it can get into the surrounding tissues and cause issues. So those are just some of the reasons we want to do that. I'm going to connect to my new needle, so it's in the packaging, and I'm simply just going to connect it. And again, the important thing you need to do, I'm going to twist it on securely. And it has its cap on, and it's ready to give to our patient. So I'm going to perform hand hygiene, double check everything again, and then I'm going to administer the medication. Okay, so that wraps up this video.
All right, here's the second one. And this is more of how you're going to prepare medications, but that allows you to see how it's done generally. And pay attention to how the interaction.
Hey everyone, I'm Deanna.
between
Done,
you and the
this
circulator.
is it. Your last chance to win a brand new Mercedes.
So I want you to pay attention to the interaction between you and the circulator.
Hello everybody, I am Mike from Surge Tech Academy, and today I'm going to demonstrate how to draw up medications. Now there are two ways we can do this. The first way is to draw up the medication from a vial held by the circulator. The second way is for us to draw up the medication we have received onto the sterile field. One of the major, if not the key concepts of medications is that we need to know and remember the 6 rights of medications. Some experts have added 2 more to make it the 8 rights of medications. Some say the 5 rights. Our textbook says 6. So for this demonstration, I'm going to stick with the 6. And this 6 are the right patient, the right medication, the right dose, the right route, right time, and right documentation. For us, it means labeling. Now, the right patient is determined during the timeout, and also verifying the patient allergies is also important at this time. The right route and the right time is decided by the surgeon. So, first, make sure we have the correct supplies, we have looked at the surgeon's preference card or the plan of care, and have determined that the surgeon wants 10 milliliters of 0.9% normal saline. And wouldn't you know it, as chance would have it, that's all we have in the lab. So, the first way we're going to draw up the medication is from a vial held by the circulator. The circulator presents the medication to us by showing us the medication label and announcing the medication and the dosage.
0.9% sodium chloride, expiration date August 2018.
Okay, 0.9% sodium chloride, expiration date August of 2018. I'm going to pull back 10 milliliters of air. This circulator is going to hold it straight up and down. I'm going to inject all the air in the vial, pull down, and get the medication. I go slow because I think it adds less air bubbles. And I also draw up a little more if I can than the 10, because inevitably I always lose half a cc when I'm getting out all the air bubbles. So next, we're going to use the scoop method. So with no hands, I'm going to scoop the needle on the cap onto the needle, make a clip. I'm going to make sure that all the air bubbles are out, and I'm going to make sure that I have 10 milliliters of 0.9% normal saline inside the syringe. At this point, I'm going to go ahead and label my syringe. Expiration date, August of 18. And there you have it, a properly labeled syringe. Also make sure that interoperatively, remember to let your surgeon know that what you're passing them when you give them the medication for the first time. Next, let's go up and draw a medication that's been received onto the sterile field. First, the circulator has shown you the vial and has announced the medication like they did before. Then they would either sterilely draw out the medication and inject it into the syringe, or they would take off the top of the vial and pour it into the med cup. So, very similar process. I'm just going to take a syringe with no needle, stick it into the medication, and draw it up. Again, I go slow and drop a little more. Get all the air bubbles out. Make sure that I have 10. Now, again, don't forget to get the air bubbles out, put the correct amount into the syringe, and once again, label the medication. Now, since I do have some medication left in the med cup, I also labeled the med cup, and I've already done this, and it just reads just like everything else, 0.9% sodium chloride, 8 of 2018. And that's it. Drawing up medications in a vial held by the circulator, and drawing up medications received onto your sterile field. So I'm Mike from Surg Tech Academy, wishing you a great day in surgery, and reminding you to be a superstar in your OR.
Okay. All right, so let's get back into more of the medication. So let's look at, just let me get back over here. Let me close it. All right, so these are table 913. These are a lot of the standard medications that are going to be used in the surgical setting. And you can see they're named by categories, generic name, trade names, and what they're used for. You definitely want to make sure that you go through these just to familiarize yourself with the names and categories of what these medications are. Of course, there's a lot of them. You're not going to be responsible for knowing every one of these. Just know that you can see there's different forms of IV fluids. We're going to go over that. There's a lot of different narcotics, steroids, and things of that nature. So those are a lot of that's the list of pretty much all of them. But then we're going to look at the different categories. And here we go. So looking at the medications that are used, you saw that big list. But then there's different medications that are used like as diagnostic agents. So this might be IV contrast, for an imaging that's needed, irrigation fluids. So fluids that are just needed to irrigate a wound, hemostatic agents. So things that can help reduce blood loss. We're going to look at each one of these surgeries just to see what kind of medications we're normally seeing. Then these general surgeon, of course, that is usually either general anesthetic, meaning they're completely knocked out, or they may be awake and just given like either a local anesthetic or a regional. And we'll talk about that a little bit more. They also may be given heparin if they are placing in any kind of vascular access device. So if they're given like a PICC line, an ART line, any of those, heparin is going to be used to keep that opened up. Now in the OBGYN, you're going to see there's a lot of different medications used here. You got oxytocin used to induce or continue labor. It's also used afterwards, you know, after there's a vaginal or cesarean birth, just to kind of help contract that and control the uterine bleeding. Carbaprost is given anytime that abortion is needed to be induced, like in the early pregnancy, whether it's I forget the word. And then methogen, this is given, you know, to try to reduce the bleeding again. And so you can see a lot of these are in OBGYN are used when they're needing to control bleeding. Rogan, this is an immunoglobulin. So this is when there's a Rh negative female who is pregnant with an Rh positive fetus. So also there's a lot of different things here that are used in hysteroscopy procedures. So you can look through these medications and just read through this chapter and be familiar with this. Otolaryngologic surgery, these, so in here you're seeing a lot of things like antibiotics that are going to be topically applied when a myringotomy is done. So that's tube placement for chronic otitis media. Nasal bleeding, this is usually stopped with, they're called nasal tampons. These are cotton applicators or patties, and these are soaked in cocaine. And that cocaine is a really potent vasoconstrictor that's used for that. Genitourinary surgery. So here we see sorbitol and glycine being used to distend the bladder. And it's also non-conductant. So that's important when we're looking at also using the ESU to control the bleeding. Lidocaine may be used as well, especially if they're going to insert like a Foley catheter. That can be painful. And then of course, radio contrast is going to be used. And then the IV dyes. Orthopedic surgery. So here we're seeing a lot of antibiotics, hemostatic agents, and steroids, and you can look through all of these. We do have some bone wax in the lab. I don't know if we've got the gel foam in there, but the techs are going to look to see what we have that they can demonstrate to you. Of course, then cardiac surgery, we've got a lot of heparinized solutions that are going to be used. Epi and vasopressin is usually always going to be present in a cardiac case. In case that there is a cardiac arrest that's needed. Also, medications for like hypertension, tachycardic arrhythmias, things like that. A lot of these more severe anesthesia is going to have that, so it won't be on your back table. Neurosurgery, there is going to be antibiotics in warm saline that they're going to use for irrigation. There also may be some heparinized saline that may be done as well for other irrigation. Contrast media, again, some of these are going to be used by anesthesia, not you. And then diuretics, so anesthesia is going to be injecting this, but diuretics, so that's Lasix, so that's going to help pull some water off, mannitol. And so all of these are used to help reduce cranial pressure. So you can read through all of these. And then ophthalmic surgery, this is a really important category because you'll see a lot of these are the same medications, right, that you've been seeing in other things, antibiotics, anesthesia, anesthetics, dyes, things of that nature. But the key with this is everything that you are labeling in an ophthalmic case, you're going to make sure it's labeled for ophthalmic use because they are prescribed differently, okay? So you just want to read through that table and make sure that you are comfortable with that information. Hemostatic, so these are medications and techniques that are used that, is going to help reduce blood loss. And in any time that there is hemorrhaging that is occurring, there is techniques that are used to reduce that loss, as well as medications like we talked about. The cocaine, that is a very potent vasoconstrictor. So sometimes different medications are going to be added to an area to prevent that blood loss. And so those are called hemostatic agents. All right, and then there's a lot of other factors that are going to affect that hemostatic state. So let's look at that. All right, so if they already have a clotting factor deficiency, so this is going to be something that is already existing. It's not brand new to the OR, and you know about it before the case starts, and so you're prepared for that. So that's hemophilia or von Willebrand's disease. So both of those, they have a deficiency in the clotting cascade. So there is a normal process that happens in the liver to create the clots in the order they need to be delivered to the body. And if there is a deficiency in any of those, then that clotting process, which is called a clotting cascade, cannot occur, and there's interference with it. So then there's not clots applied to an area where there's bleeding. And so that is those are genetic. Now, if there is liver disease, that's going to interfere, because that's where our normal clotting factors are created, is in the liver. If they're on anticoagulant therapy, so if they're already on medication to inhibit that clotting factor or that clotting process, like heparin or Coumadin. If they're on antiplatelets like Plavix or aspirin or Ticlid, different things that are providing the reduction of platelets, that could be a problem. Aplastic anemia, alcohol-induced liver failure. So those are all things that are pre-existing that you're going to learn about in your timeout situation. So you'll know if you are needing to be on higher alert for possible bleeding. And then, of course, there is about a 50% of people in post-op where bleeding occurs, that is usually related back to that there was poor hemostasis during the procedure. So you want to make sure that you are helping by anticipating what's going on, being prepared to assist with the hemostasis, either by technique or by the medication. And then, of course, thermal and chemical methods. So thermal would be cooling devices can be added to slow bleeding, because we know that cold causes vasoconstriction. Chemical methods as well. So then we're talking about some of those medications that can be applied for that. Bone wax is going to be used. Let me make sure we don't. Okay, here we go. Bone wax. So this is something that's going to be used, especially during orthopedic cases, and it is applying this. It has clotting factors in it, mixed in with it, and so it's used to stop bleeding within the bone material. You'll be able to roll it into balls, and it's applied to the wound site with like a Freer elevator or a dissector. And then in the chemical area, then we're looking at different agents, so different medications that are being used to help the body's clotting mechanism occur normally. Then we have absorbable gelatin. And so these are like gel foam, gel film. And so these are collagen. And so these have different components. So you may see this one is pork gelatin, and then and it is dried, and then you'll reconstitute it. So you're going to use a sponge and soak it in saline and then soak it in the thrombin material. And so that's going to help with the clot. And so using those to help really create that clotting effect. And then also we can see epinephrine being used because that's going to help with that vasoconstriction. So reading through this, there's a lot of different types of gelatins that are used in the market now. And then of course the hemostatic matrix. So this is like FlowSeal or Surgiflow. And these are, again, these gelatin granules, and it has human thrombin embedded in it. And so they can take that and just apply it to the wound area that is bleeding, and it will expand in the tissue and it creates kind of a compression. So I kind of think of this and even the gel foam of like, you know, that insulation foam that you can do. And once you spray it, then you watch it and it continues to expand. And so some of these do this, the hemostatic matrix and the gel foam does that. You insert it into an area and then it expands, and that creates that compression. So it's like holding a cut, and it's performing in that internally though. And then you've got absorbable microfibrillar collagen. And so these are compounds, and they're preloaded in these little applicators, or they're in either a dispenser type thing or in a sheet. And so these are used to really kind of help create platelet aggregation to an area so that it will form a clot. Okay. And then of course we've got oxidized cellulose that can be used, silver nitrate, epinephrine, thrombin sealants. These are a lot of things that we'll see. Now let's talk about vital signs. This is really important when we're looking at your role. So you're in most facilities, you're not going to be responsible for taking the vital signs, but it is important that you are familiar with what the vital signs should look like, because you're another set of eyes and ears that's helping to watch those vital signs and make sure that there's nothing that's really out of the abnormal. Okay, here is the temperature that we're looking at. So this is the normal body temperature that we're gonna be monitoring. And if it's an oral probe, 98.6 is the average in that range. And then rectal is gonna be 99.6 and axillary 97.6. And just know that this is the standard that is followed all the time, but it is a wide range of normal. This is kind of the average of normal, but it does not mean that if you're not 98.6, you're abnormal. Like I know a lot of people that their normal is in the 97 range, or their normal is in the 99 range. And so just know that this is the average. And now you're going to be looking at it in a Celsius form though, because that's what it's going to be in the hospital. So 37, just always remember 37 is your normal range. And so, and it's tighter when it's Celsius because it is smaller. There's a smaller amount of flexibility there. So 37 degrees Celsius is considered your normal. Okay. Oh, it went one, sorry. All right, and then we're looking at pulse and respiration. Let's look at the pulse and see what that normal is. So it's around, and it depends on what age group we're looking at. So if we're looking at a newborn, it could be 130 to 160. Infants, 110 to 130. Children to 7, 80 to 120. Over 7, 80 to 90. Adults, 60 to 80. There's different places to feel that in the body, so you can look at those pulse points. Here's some abnormalities that can happen and why that can happen. So you want to just read through this. Respiration, I know I'm flying, this is a lot of information in this chapter. Normal respirations, Here you've got infants 30 to 60 per minute, children 1 to 7, 18 to 30, adults 12 to 20 per minute. So this is really going to change based on their age. And so just being familiar with that is what's important. Breathing patterns. These are different types of breathing patterns that you'll see in the OR. Of course, eupnea is normal. If they're apneic, there is no breathing. Bradypnea, it's slow. Cheyne-Stokes, so this is fast breathing for a period, and then apnea. And then they'll go back into fast breathing and then apnea. Dyspnea, there's having difficulty and it could be painful. Kussmaul's, this is fast and deep. And you'll see this a lot of times in like an acidosis state. And I've seen this. This is pretty common in like ketoacidosis in diabetics. Tachypnea, so this is a rapid breathing. And then let's move to blood pressure. So blood pressure has a range. So you have two numbers, a diastolic and a systolic. Systolic's on top, diastolic's on the bottom. And here you can see all of these normals. And so for children, we normally see like newborns, 50 to 52 over 25 to 30. Children, 95 over 62, up to 10 years, 100 over 65. And then adolescent, like 118 to 75. And then in adults, it changes, okay? Because then we have a lot more stress. We have usually, different diet, exercise regime. And so normal textbook is 120 over 80, no more than 120 over 80. If pre-hypertension is anything above 120 or anything above 180 or above 80. And then hypertension, you can see, is 140 over 90 up to 159 over 99. Stage 2 is 160 over 100 or greater. And so these are the categories set in place by the JNC8 is the committee that creates this standard. And then there's monitoring devices that you're going to see. So these are devices that are going to be in the OR that are going to give feedback on what all is going on during the time. And you can see baseline vitals are also going to include the weight, the height, the patient's history, and their physical. And I think there was, we might have gone through all those, but we'll look and see. Monitoring device, so these are things that are going to be present in the OR. So we've got an EKG monitor, we've got blood pressure monitor, if they have an ART line or a PICC line, or a Swan-Ganz, then that catheterization feedback is going to be on the monitor, temperature, pulse ox, and then a BIS monitor. And I'm going to show you what those are. So here is your typical, this is called a hemodynamics monitor. So this is your ECG reading in the green with your mean heart rate. This is the saturation monitor, so the O2 sat on the finger, and that is showing the reading, the cycle of the reading, and it's averaging around 97, which is good. And then this is the respirations, and you can see they're averaging 15 breaths per minute. This is your blood pressure, 122 over 89, and this is a mean. And if they have like a Swan-Ganz or an ART line, it would be on here as well, and I'll show you that. So their pulse is averaging 79. Their temperature is averaging 37.2, so it's just slightly elevated. You can see these are the ranges that are set for the alarm. So the alarm is set at between 36 and 39. On the temperature, heart rate, it's set between 50 and 120. For the saturation, it's set between 90 and 100. And for respiration, it's set between 8 and 30. And okay, and then here's another one. You can see the rhythm is very different as to this one. This is normal sinus. There's PQRST. Very nice rhythm, no abnormalities. This one, it has a very pronounced QRS signal. Their rate is around 119. You can see here, their parameters are set a lot wider. 70 to 250 is that alarm range. Here is the CO2 monitor. It's not connected. This is a respiration monitor. It is counting breaths per minute, and that's at 21. That's pretty high. And this is the pulse ox, and it's reading at 99%. I'm sorry, here's the pulse ox at on the bottom, and it's at 99%. Here is your breaths per minute at 21 breaths per minute. Blood pressure is 97/69, and the temperature is off right now. You can see the alarm is set at 102.6. And then this is a BIS monitor. So this helps the anesthesiologist determine the level of consciousness or unconsciousness. And so the monitor is applied across the forehead and in this jawline one. And then the monitor is letting them know what level of consciousness the patient it is. So it helps them monitor how deep or how shallow they are being anesthetized. And so then there is an optimal level. And so then they can adjust that. So in the OR, you're going to see that system set up. And let me go back to the book because I know that there is a pretty decent picture. And I think I might have got one as well. Yeah, so here is anesthesia's machine. This contains like the airway delivery. These has different medications involved. And this is basically anesthesia's ventilator and their monitoring system all in one. And so then in the OR, you're going to see, and this is usually going to be on the anesthesia provider, that they're going to have the respiratory analysis and anesthetic, and you just saw that stethoscope, because once the ET tube is placed, they've got to listen and make sure that it's in the right place. A Doppler may be used for any kind of IV access that's being needed that's hard to obtain. A peripheral nerve stimulator. So if procedure is needing to analyze and monitor the nerve action through the procedure, a peripheral nerve stimulator may be used. And then arterial blood gases may be obtained as well. And if that's the case, then the anesthesiologist is usually going to have an art line to draw that from. Here you can see again is the anesthesia machine, and it does contain the airway delivery and maintenance device. You may see some hypothermia and hyperthermia devices. So like I talked about, you may have air-filled heating blankets. Also, you may have ice blankets. So there also may be ice brought into the OR to cool a patient off. And then there's, of course, the IV fluid delivery devices, and those are just an IV monitor. Make sure I'm not missing anything. What's next? There's the bispectral device. We went through that. Oh, and on that BIS monitor, I did forget to mention. So 100, so it's measuring the brain waves, and 100 is when the patient's wide awake, and then anything under 60, they're unconscious. And so as the numbers changing on that monitor, they're able to see what level of consciousness they're at. And then that was that monitor that I showed you. All of that information. Stethoscope, of course, is going to be used. Doppler, peripheral stimulator, ABGs. We saw that equipment. So here's the anesthesia machine. We've got one in our lab that looks very similar to this. So please check it out tomorrow night and see if you can figure out what does what. So this is where the ventilator portion of it, that's the bellows that goes to that. There's their monitor. There's another monitor. This is going to be their gas intake and monitoring that. So there's just, you can see there's a lot of monitoring that's done in the OR. And then the airway delivery maintenance device. Let's see if there's a picture. Yeah. So this, we're going to use an ET tube to insert into the lungs. to be able to provide that airway. You'll see a laryngoscope and different types of blades that are used to insert that ET tube. And then there's also called an LMA, and this is a laryngeal mask airway, and this is where an ET tube is not needed as much. This is just inserted down into the airway, and then the balloon is inflated, and that prevents any gastric material from, I think that they had a picture of the, yeah. So here, this is called a bear hugger blanket. And so it's blowing warm air into this blanket continuously. So it will warm the patient. And then they can do rapid infusion, and they can warm the fluids, and they can also do infusion control. So they can add warming type of medications to the fluids as well. Okay, so there's also some components of hypnosis that are going to be used to help reduce the pain signaling that occurs. There can also be different forms of anesthesia used, and then amnesia can also be a different way of helping a patient not carry the effects of the anesthesia or the procedure. Of course, optimal patient positioning is going to be key when we're talking about making sure that the patient is the most comfortable to not cause any discomfort. I totally forgot to give you guys any key words, didn't I? Looking back at the O2 all of the hemodynamic monitoring, I want you to remember, a capnogram. It's capnogram is what measures the outgoing CO2. And so that measures, it helps measure like respiratory alkalosis and acidosis, and that's capnogram is CAPNOGRAM. So that was the only value that wasn't really shown. It looked like they had one, but it wasn't turned on at the moment. So, so with that, we're going to, look at all of those vital functions. And so we need that homeostasis. And knowing what homeostasis means, it means everything is in balance. And so we've got to make sure that everything is in balance so that the organs work optimally. Okay, let me see where we are in relation to how much we have left of this. All right, got a good ways to go. Okay. Let me jump back into this. Oh my gosh. Okay. There we go. Okay, now let's start looking at some of these anesthetic agents. So we've got two different ways. So in the very beginning, they're given an inhalation. So you'll know they'll put the mask over the patient. And so that takes them down on the first level of anesthesia. And then they're going to use the injectable. So they're going to then inject through the IV. And this is going to help start altering that patient's level of consciousness. If it's done regionally, that's going to be looking at sensory nerve impulse transmission in a specific location of the body. So if we're doing a regional anesthetic agent, then we're going to look at some pictures of this. We may do a nerve block or a beer block, so either way, just to help prevent that impulse from happening. All right, so there's a lot of different tables in the book where it's talking about the team member roles. And this is really important as we go through here for you to know what your role is. And you can see here in this table, this is pre-op. So this is just circulator and anesthesia. when we get into the OR, then, looking at what your role is, this is really important, especially in this first stage where anesthesia is working on the levels of consciousness. One of your main goals, and this is your second key word, is be quiet. Because when the level of consciousness are dropping, there's theories and studies that show that hearing is very acute during this time, and it can trigger patients. So, also using words such as needles, knives, things of that nature. And so you just want to be very conscious of your noise activity during anesthesia. And anesthesia may ask that everyone be quiet and keep the noise to a certain level until he or she is able to make sure that the patient is at the level of consciousness that they're no longer stimulated or triggered by hearing. And so let me get back to there. All right, so let's get back to there's some more tables we want to look at. So here's different anesthesia. Let me get to that table. So there's different depths of anesthesia. We're going to look at that. So stage 1, this is the first stage. This is the amnesia stage. And so they start to lose consciousness there. Stage 2 is the really important one, and you can see it's in blue here. That's what's called the excitement or delirium stage. And this is where you've really got to be quiet, because they can actually start having vomiting, laryngospasms, hypertension, tachycardia. And so everything is kept really quiet during this stage just to get the patient through this phase. And so once they enter the stage 3, then this is where they're unresponsive to painful stimuli. They've lost any eyelid reflex, and they're no longer breathing on their own. And then, of course, stage 4 is that level of overdose. And then we're going to look at a little bit more. And so then there's 4 phases of anesthesia. There is the induction phase, there is maintenance, emergence, and recovery. So let's look at that. This is really important that you just have a good idea about these phases. So like I talked about earlier, induction. So this is during this time is when their state of consciousness is going from conscious to unconscious. They may, this is where they're using the inhalation gases to start that induction. And once that has been obtained, then the ET tube will be inserted, whether it's an LMA or an ET tube. And the hearing is the last sense to be suppressed. And so this is really important that you're conscious of what you're talking about during this time and keeping your environmental noise to a minimum. Now, once they're in the maintenance phase, this is the most dynamic portion of part. And so this is where everything is occurring. So the case is happening during the maintenance phase. Anesthesia is monitoring everything, making sure that it stays in this maintenance phase while the surgical case is taking place. Now, once the case is completed and they need to be woken up, the emergence phase starts. And so this is the goal of this phase, is to have them as awake as possible. And then once they're up at a certain level of consciousness, then they can be extubated, because then they're breathing on their own. And then they move into the recovery phase, which they're going into the PACU. And so this is, they're breathing on their own. Their level of consciousness is high enough that they're able to maintain their bodily functions without any intervention. So those are the 4 stages, or the 4 phases of anesthesia. Okay, there's another table talking about your responsibility. So here you want to make sure you read through every bit of this and are familiar with what's happening at each phase and what you're responsible for. So of course you can see absolute quiet, may be requested during that induction. with IV or inhalation agents. And so you may have to stop your prep activities at the time. And when they're intubating the patient, you've got to be prepared for the possibility of any kind of emergency tracheotomy, because if there's a severe airway problem, you've got to be prepared to assist with the tracheotomy. And then once the ET tube is placed, you know, you're just assisting with the team of monitoring the patient for any changes. And then the anesthesia will give permission for the pre-op activities to begin or to continue. And so then you're going to continue as you were and consult as needed. And you can see then a lot of this is just things that you already know that you're going to be doing. And just I definitely want you to read through all of your responsibilities. Now, here's some of the advantages, of course, to general anesthesia. You know, it's good that the patient is unaware of what's going on during that case. And then also making sure that there's an adequate airway secured without the risk of aspiration. And aspiration means inhaling substances into the lungs that may be coming up from the gastric system. So it's a really important way to protect the lungs. Also, medications can be easily titrated to help control the level of the depth that the patient is in. And then the muscle relaxation is important because intubation and extubation is challenging if a patient is awake because the muscles are responding to that invasive procedure. And then, of course, it's easy to access the surgical site. Okay, so here's some of the risk and complications that are associated with general anesthesia. Of course, aspiration, like I talked about, they could have laryngeal spasms or bronchospasms that can occur just with the introduction of the ET tube. So that's where we got to be prepared, make sure that if there's an emergency tracheotomy done, we're prepared for that. Malignant hyperthermia. This is, remember from last week, this is that sudden spike in temperature. We got to be prepared to assist with cooling the patient. A pseudocholinesterase deficiency syndrome. So this is when the enzymatic, so there's a deficiency in the cholinesterase, and so then the muscles are not able to contract. And this is not very common, but you may see this happen. And so then they're going to push some medications. It's called succinylcholine, and that will help to create that. It'll create a paralytic effect, but that it will correct the deficiency. Allergic reaction, shock, or cardiac arrest. So anytime a patient, if we're looking at shock, then Trendelenburg is, of course, the first reaction that is going to be taken. And you can see the OR table in this picture. That's Trendelenburg, placing them in a 45-degree head down position to reestablish the blood flow. Okay, we're going to look at table 930 now, looking at the different, we've already gone through the risk. Oh, let me go back one. It might have missed. Sorry, we got a phone for our business and now it's ringing all the time because of solicitors. So you can see here is the level of fasting that's required. And like I said, all adults are, or everyone is 8 hours or longer for solids. And there's the NPO. Now, if this is something I want to cover really quickly because it's not in the PowerPoint, but if you're requested to assist with cricoid pressure when the anesthesia is trying to intubate, this is how you do it. And so what it means is that they're not able to get the tube through the airway area because it's trying to go into the esophagus. And so you can see here's the esophagus that is on the back side of of the trachea. And so when you're applying cricoid pressure for them, it will help direct it into the right space. And so anesthesia may ask you, this may be before you're sterile, if you can apply cricoid pressure, and that is it. You're just going to place hand and finger and thumb over that cricoid area, which is a bony area, and put downward pressure, and that way they're able to intubate fairly easily. Then we talked about the laryngeal spasms. And shock, of course, that's when you're going to put him in Trendelenburg. Cardiac dysrhythmias, those are going to be either managed by medications, or cardiac arrest is going to be managed by CPR and ACLS, as well as medications. All right, so here's some of the agents that are going to be used in the anesthesia process. So nitrous oxide, so this is added to a lot of the different gases because it reduces the concentration, because nitrous oxide is very thin and it can get through tiny areas. And so it helps carry the other gases along, so then the other gases are not needed at such high doses. Here is a lot of the inhalation anesthetics. You can read through those just to be familiar. Then this is the induction agent. So this is going to be given IV. So propofol is the #1, and here's all of the different names for that. And then ketamine is a dissociative agent, and so that helps patients not remember anything in the case. And then opiates and narcotics, these are going to be given for pain, as well as a sedative that's going to help with that remembering of it as well. And so Versed is the #1 that you'll hear about, as well as diazepam and lorazepam. And then the narcotics again for pain. And then here's a lot of neuromuscular block agents. You'll be getting more familiar with those the more that you are in cases. And then the vasoconstrictor, the #1 is epinephrine that you'll be aware of and be using. Here's some of the inhalation agents. We talked about that actually. And then oxygen is going to be used. It is not necessarily an anesthetic agent, but is going to be provided through that ventilation system where the airway is being managed. And then we talked about the nitrous oxide, how it is used, and it's the only true gas. But as I said, it helps carry things through, and then it also helps provide both anesthesia and pain relief. So, and it also helps to reduce PONV, so that's postoperative nausea and vomiting, which used to be a super common occurrence. And so with the addition of nitrous oxide to the gases now, or to the anesthesia agents, it's helped to reduce the PONV greatly. And then your volatile agents. So these are those inhaled vapors that are used in the initial phase, of course, and that helps to reduce the level of consciousness. You can read through all of those and just be familiar with the different inhalation agencies or agents and how they help with that induction as well as the recovery. And then there's a ton of those, as we saw in that table, that are the IV agents. And so, of course, a lot of those are going to be dependent on what we talked about in the beginning, what their indications are, what their what their dose is, and how they're acting. And so that's really important. And then the induction agents, so these are the ones helping with that transition from the state of consciousness to help with go from stage 1 to stage 3. And so it really gets them quickly through stage 2. And you can see there's that propofol like we saw in the table, a lot of those. And then those dissociative agents, again, that's interrupting with the pathways in the brain to help them be unaware of their surroundings. And ketamine's the #1 on that one. And then we're familiar with the opiates as far as pain medications. Okay. So the IV agents, these are directly injected into the bloodstream. So they act really quickly. And so IVs are always present in an OR situation, and typically you'll have 2 or more of those. So I'll pause just a moment. Okay. And then we talked about the induction agents and how it takes them to through that rapid transition. All right, we covered all of that. Benzodiazepine, so these are sedatives, and they also have some benzodiazepine antagonists that are always used to help reverse those effects. And so that's helping to bring the patient out of that sedative state. Then the neuromuscular blocks, these are helped with relaxing, and it helps with pain after the case as well. Then there's some non-depolarizing agents. So these are used to help with reducing muscle contraction. And then we have depolarizing and muscle and non-depolarizing. So these act in opposite. So they help either the muscles not be able to contract, and then at the end of the case, they're given to help the muscles be able to contract again, so muscle use can be restored. And then again, we talked about the neuromuscular blockade antagonism, and so to interfere with that that pain signals, and it helps with post-op pain. Here we talked about we can talk about antimuscarinic agents. Again, that is helping with muscle contraction and relaxation. NSAIDs, of course, this is anti-inflammatory medications. Gastric acid management, just to help the gastric acid not be in excessive and causing issues there. Lubricants may be used just to allow a procedure to happen easily. And then antiemetics, so this is to reduce nausea. All right, solutions that are going to be used in the OR setting. So we're talking about different IV solutions. So ringer solutions and lactated ringers, both of these contain electrolytes. And so both of these will be used in situations where there's an electrolyte imbalance or a fluid imbalance, or if there's some mild acidosis. Now, D5W, so this is 5% dextrose. This is used when there is either water loss or if there's hypoglycemia, so it'll correct both of that. And then your normal saline, which is 0.9% saline solution, this is using typically just to kind of give a state of maintenance. And then it can be used also if there's like a sodium or potassium deficiency, or if there's metabolic alkalosis. All right, so we can have situations where there is induced hypothermia. So if they're needing, in a case, blood flow to be greatly reduced, so that circulation to be reduced, they may induce hypothermia to create that. Also induce hypotension, so reducing the blood flow so that there's less bleeding at the site. Okay. And then there is neuroleptin neuroleptiналgesia or neuroleptinesthesia. So let me get to those because those are a little bit different. Okay. Here we go. So neuroleptiналgesia is using high doses of tranquilizers. So this is reducing like their anxiety, providing them with some sedation and amnesia, and allows them to still respond to commands though. So this may be used, you may actually see this being used in brain surgery because they need them to be able to respond to commands. They will have amnesia though, so they're not going to remember being awake during having brain surgery. So this is some of the what is used in that neuro case of brain surgery. And then the neurolepto anesthesia, this is going to be used to supplement with the inhalation part of it. So these are two things you just want to be aware of that is used during the neuro cases. Not all of them, but some of them. Okay, so then we're going to look at another table, and this is about nerve conduction blockade. So this is really, really common in the OR. So you want to make sure that you're familiar with this, especially if you're looking at working in ortho, because most of the time these nerve blocks are given pre-op, just before they go in for the case. And so it helps anesthesia not have to apply as much pain medication. So you can see that there's a topical anesthesia given and a local, and then there's regional anesthesia given. They can do either a nerve plexus block or a spinal block or an epidural or a beer block. So let me show you some of those, and you can read through all of this, but let me get to those pictures real quick. Okay, so this is a brachial plexus block. So you can see here they're looking at going in between the scalene, so interscalene, and then subclavicular or supraclavicular, so above the clavicle, and then infraclavicular, so underneath the clavicle, and then in the axillary region. So there's 4 different regions that a block can be given depending on where it's needed. And then a Bayer block or beer block, this is where you use an S-mark bandage, and you've seen those blue, big rubber band looking bandages in the lab. And then there's a double cuff tourniquet added, and then the lidocaine is added. And so this is providing kind of like a local anesthesia to the region. So if there's going to be a distal upper extremity, so it's usually the arm. And so this is usually where you see this procedure being done. Okay, let me get back, make sure I covered everything here. So this is the nerve conduction blocking agents. And this is in the next table. Let's look at that table real quick. And you can see there's a ton, of different types of canes that are used. And so they're all either lidocaine or cocaine being used. And this is just to help with block that nerve conduction that indicates there's pain. So, and then we have a group, it's called an amino group, amino-amide group. That is, it gives a really long onset, so it doesn't kick in for a long time, or it lasts a long time. And here you can see different ones. Bupivacaine is one of the most common after lidocaine, and bupivacaine is because it's 4 times more potent than lidocaine. So lidocaine is used as a local anesthesia. It's really fast onset, and it has a moderate duration as well. But bupivacaine is 4 times longer than that. So it's longer onset and greatly a longer duration, of course. So, and then the amino ester group. This is another group of medications that includes the cocaine and procaine and tetracaine. And so this is providing that blockage in that pain signaling. And you can tell, of course, this is a really high classified control substance, and it has a high toxicity level. And then we have other things that can be added to the nerve conduction blockade process. So hyaluronidase and epinephrine. So both of these can be added to either slow down the absorption rate and or to help allow that to be absorbed in the correct areas. Okay. Let's see what we got next. Topical. So this is when we're looking at putting a anesthesia directly on the skin. And so of course it's limited to just the local region that comes in contact with that agent. So anytime that there's a medication that is applied topically, you're only going to get that effect where it comes into contact with that the skin, that medication with the skin. And then cryoanesthesia, so this is using cryotherapy to reduce pain to an area. It can be done with ice, or it can be done with a device that applies cold treatment to it. Okay. Local infiltration. So this is injecting a nerve blocking agent. So any of those medications that we've read directly into the tissue surrounding that peripheral nerve. And that's what we see in these pictures, okay, that I showed you. So we're seeing that an injection of a anesthesia agent is infiltrated into this area that is surrounding the nerve. So then it's kind of absorbed into the nerve, and then we get that blockade effect. And then of course, MAC. So here, anesthesia is going to combine applying that nerve blockade with other types of agents. So they may be an analgesic to reduce pain, sedative to reduce the level of consciousness, or amnesic to provide the loss of memory of that event. And then of course that regional blockade, that is providing anesthetic agent along a nerve tract. So it's not just one local, it is a regional, it's broader. It'll provide pain relief along an entire nerve tract. But if we're looking at nerve plexus, so this is a really big, so the regional blockades and the local, so a lot of times those are done just for pain management. So you'll know patients, that get cortisone injection, that's basically a local or regional blockade. But if we're looking at someone going in, say for rotator cuff surgery, and they need a nerve block done, this is a nerve plexus done, and then beer block is done, or Bayer block done when there's like an upper extremity case, so like the hand or forearm. And this is both of those, and I showed you those. And then a spinal block. So this is injecting an agent directly into the cerebral spinal fluid. And I think I found a picture. Yeah, so here is the spinal cord. And then this blue is all of this blue is the cerebral spinal fluid. So the injection is going to occur directly into the cerebral spinal fluid. Now, a epidural, and I'll go ahead and talk about, I think it looks about it in a minute. So the epidural is going between the dura and the subarachnoid. And here you can see the dura is dark blue on the outer, the subarachnoid is the light blue in the middle, and then the pia is directly on. And so the anesthesiologist is very skilled in the epidural process to get it in between those two areas. Okay. And then we can look at the different team members during spinal anesthesia. Let's look though, I think they might have a picture of a, no, they don't have a lot of pictures in this one, I didn't see. Okay, so here's the procedure for the spinal anesthesia. Here is the positioning that is needed for that, because as you can see, the insertion is directly through this opening and into the cerebral spinal fluid, or if we're talking about an epidural, it's in between the meninges. Okay, and there are, of course, some advantages and disadvantages to this. So we may see, of course, an advantage is going to be permitting them to not have to be under general anesthesia, so they're able to breathe on their own. And we see these used, of course, a lot in L&D, so things that are used, spinal blocks or epidurals are used. Epidurals are primarily used in L&D today. Okay, so it's directly above the I'm sorry, it's on the outside of the dura mater, and then it's absorbed, and then it absorbed into the central spinal fluid, cerebral spinal fluid. All right, here's what I wanted to talk about real quick. So this is your role in the spinal anesthesia. So again, you're going to maintain a quiet environment, and they may need quiet during the insertion of the needle. You're going to help monitor the patient, and then you got to be conscious that the patient's going to be awake during the entire procedure. And so then you're going to be aware of that in your conversation. So of course, then read through the rest of this as far as your responsibilities there. Now, talking about non-traditional anesthesia options. So hypoanesthesia, so this is when the patient is on board for this and working with the anesthesia. Hypnotherapy may be used in this to reduce the pain signaling. And so it's really helpful in that induction phase. And it's really good for children as well. So it helps focus the children on something predetermined, and it allows them to be less aware during that time. And, you know, of course, the mask has a certain smell. And so anesthesia providers will usually include some form of hypnosis in there. Now, acupuncture also has been found to really help reduce the intensity of the pain perception. And so that's a really up and coming thing that's allowing less medications to be used. Now, following the surgery, we've got post-anesthetic care, of course. And here we're looking at what is everyone's role. And you can see at this point, you're removed from this, but you do want to be familiar with what's going on in the patient's case so that you are able to provide support if that's ever needed. So just want to read through that and make sure that everything is familiar, that you're familiar with it all. So in this chapter, we've reviewed the actions, the mode of administration of drugs and the anesthetic agents, the systems of measurement, terminology that's used, abbreviation that is to be used and not to be used, methods of hemostasis, so how we're maintaining blood loss and blood replacement, and then the equipment used as an adjunct. So all the different things that are going to be used. Okay, I'm going to get the the video ready. Give me just a moment. All right, we're going to look at prepping and draping today. And I want you to tell me what you found very interesting or learned this time from the video.
The ultimate goal for all healthcare personnel is to provide quality care to the patient. An important factor in quality care is patient safety, particularly when the patient is going to have surgery and may be at risk for infection. The surgical technologist plays an important role in keeping the patient safe when performing the surgical skin preparation and draping the patient. The surgical skin preparation is carried out to remove transient organisms from the patient's skin and to reduce the number of resident organisms on the patient's skin. Since living human tissue cannot be sterilized, The goal of the surgical skin prep is the same as asepsis, to keep the microbial count within the sterile field to an irreducible minimum. Draping the patient is performed after the surgical skin prep. Drapes are applied to the surgical patient as an extension of the sterile field that has already been created in preparation for the procedure. Drapes are applied to expose the surgical site, create a sterile barrier, and to maintain a sterile field. If either of these duties is not performed properly, the opportunity for infection can be greatly increased. The items necessary for final skin preparation should be arranged on a separate sterile mayo stand or prep stand. Prep packs are available in sterile form containing all the necessary supplies except for the antiseptic scrub solution and paint solution. There are several varieties of prep solutions. Iodine solutions are one type of a surgical prep. They provide rapid reduction in skin microbial counts, but should be removed after 2 to 3 minutes to prevent skin irritation. These iodine preps can come in the form of a scrub and paint, a gel, or a one-step prep. Alcohol preps provide a rapid and significant reduction in skin microbial counts. Iodophores are less likely to cause skin irritation and do not need to be removed. Chlorhexidine does not provide as rapid a reduction in skin microbial counts as alcohol, but provides a longer residual effect of 5 to 6 hours. This effect remains active in the presence of blood and other organic material. Hexachlorophene must be used for several days prior to the surgery because it builds up a cumulative antimicrobial effect. The agent chosen for use should be based on the particular patient, skin sensitivity, and the surgical site. The recommendations of the antiseptic manufacturer, like exposure time, must be followed. Tip: iodine preps are contraindicated for those patients who have an iodine or shellfish allergy, and for those patients, a hibiclins or alcohol prep can be used. Single-use applicators contain an alcohol-based antiseptic solution that leaves an antimicrobial film. They are self-contained units, and after activation as per manufacturer's instructions, the solution flows onto the applicator sponge. They are discarded after use.
Different preps are used. Sometimes it's on surgeon's preference, what kind of prep they would like to use. Sometimes it's based on the patient's allergies. If a patient is allergic to iodine, we don't want to use iodophores, things like betadine. So we'll use a prep like Hibiclens. Sometimes they'll use a FISA-Hex prep. Plastic surgeons sometimes don't want the staining of a betadine prep because it does turn your skin a funny color, a little orangish yellow, and they want a clear prep so they can see the skin better when they're working on it.
Standard prep is usually betadine scrub and solution, or DuraPrep has become very popular. If a patient is allergic to betadine, then we have to use Dynahex, which is more of a clear solution that doesn't have the betadine solutions in it. And they'll use either Hibistat, alcohol, or just use that as a scrub, the Dynahex.
Draping begins after prep. Responsibility for draping varies. However, it is always performed by sterile team members. The surgical technologist may pass drapes in order to the surgeon who drapes with the surgical assistant, or the surgical technologist may drape with the surgeon or with the surgical assistant. All parties involved are expected to know proper draping procedures, details about the drapes themselves, folding patterns, and the potential difficulties associated with specific drape types. Because some drapes are large and because the possibility of contamination is increased during draping, the circulator should participate as a careful observer of the procedure. Abdominal and thoracoabdominal preps are the most common preoperative skin preps performed in most operating rooms. Here is an example of the correct way to prep a patient for an abdominal, thoracic, breast, or chest procedure. Several necessary procedures will have been carried out prior to performing the surgical skin prep, including anesthesia administration, Foley catheterization, exposure of the surgical site, and skin marking. Hair that may interfere with ESU electrode placement or performance, the incision site, wound closure, or dressing application may be removed according to surgeon preference, facility policy, age and gender of the patient, and the planned operative site. Hair removal should occur as close as possible to the time of the planned surgical procedure in order to reduce the risk of microbial growth at sites where breaks in the skin surface might occur. Before you begin the skin prep, also make sure you assemble needed supplies and equipment, adjust lighting for optimal prepping, re-verify patient allergy status, and wash your hands. If the patient is awake, remember to explain the procedure to them as you perform each step. This will give them added reassurance during this time.
Begin the skin prep by positioning the patient to adequately expose the skin prep site. Next, open the prep set and supplies. Don sterile gloves using open glove technique and organize the supplies within the prep tray. Place sterile towels around the operative site. Next, clean the umbilicus with a cotton-tipped applicator. With a sterile gloved hand, put a sponge in antiseptic solution and apply to the patient's skin. Using circular motions, start at the incision site and widen toward the outer edges. Use caution to avoid the removal of any operative site markings the surgeon may have made prior to the skin prep. Discard the sponges after each single use. Do not use the same sponge to go over a previously prepped area. Repeat this process for a minimum of 5 minutes or until the counted number of prepared sponges have been used. Blot all areas of excess scrub solutions. Continue by applying the paint solution. Starting at the incision site, use circular motions widening toward the outer edges. Again, discard the sponge after single use and do not retrace. Repeat this process. Finally, carefully remove sterile towels to protect the prepped area and discard them. It should be noted that the surgeon will blot excess in pooled prep solution after the draping process is completed. Make sure you properly dispose of all materials, including your gloves, and that you wash your hands upon completion. The circulating RN will document the process as required.
Watch this scene to detect the errors that are being made while the prep is being performed. Did you pick up on these important errors? The OR team members did not begin the prep at the incision site. The OR team members did not use circular motion. They used the same sponge twice. And they went over a prepped area with the same sponge.
As far as prepping goes, one of the most common mistakes I see made is they just aren't sure of where the boundary of the prep is. So students tend to prep too narrow than too wide, forgetting about the circular motion as far as prepping goes, and they'll think it's like painting a house where you go back and forth, and they forget that we do things in a circle. Also, learning what's contaminated and what's clean, or a dirty area versus a clean area. And you may see them start in a dirty area and then go to a clean, so they really have to get that idea in their head of what's clean, what's dirty, where they can start and where they can't.
After the prep, draping is always performed by sterile team members. The technique for draping the abdomen is illustrative of the most basic type of draping. The technique is also used when draping the back, side, or any relatively flat surface that does not require manipulation of an extremity. Slight variations will occur due to patient position, surgical site, size of the area to be draped, and surgeon's preference. This technique for draping is used for the following types of procedures: general, gynecological, cardiothoracic, vascular, plastic, and reconstructive specialties. Organize the drapes in advance of need. Drapes are stacked in order of intended use. Drapes are generally passed in the folded position. They are never passed over non-sterile areas. The protective covering is removed from a self-adherent drape prior to use. Sterile gown and gloves may not contact non-sterile personnel or items. Personnel should maintain a safe distance from the operating table until the drapes have been applied. Drapes are not relocated after initial placement. Misplaced drapes may be covered with another drape if necessary. A contaminated drape should be removed by the circulator and discarded. It may be necessary to re-prep the area. Any portion of the drape that falls below waist or table level is considered contaminated. Sterile gloved hands are also not allowed below waist or table level at any time.
Present the edge of the sheet to the individual assisting with application of the sheet. Unfold the sheet towards the feet first as both individuals approach the patient. Make sure you protect the gloved, sterile hands by cuffing the sheet and not reaching below the surface of the operating table. 4 towels or sticky drapes are used to outline the intended surgical site. The first towel is placed on the side of the patient nearest the individual applying the drapes. The second towel is placed inferiorly. Place the third and fourth towels. Provide towel clips if necessary. Prepare the laparotomy sheet by removing the strips from the adhesive portion of the drape. Orient the laparotomy sheet by placing the fenestrated portion of the drape over the intended surgical site. Simultaneously, slowly unfold the sheet with both sterile team members on each side of the patient, keeping hands cuffed under the drape. As you unfold toward the feet, continue to hold the unfolded upper portion of the drape in your hands. Carefully lay the drape over the feet. Do not shake it. Make sure to protect the gloved hands from contamination and do not reach below the surface of the operating table. Unfold the head end of the sheet in the same fashion. Be sure the arm boards are adequately covered and protect the gloved hands from contamination by covering with the cuff of the drape. Tip: holes discovered or made after draping must be covered immediately or the drape must be replaced. Covering small holes with an impermeable towel that has an adhesive edge works well in many cases.
Draping is creating the sterile field actually on top of the patient. And that should be our focus, is starting right at the incision site and building in small circles outward. You know, we start with the little towels and drape off the area closest to the incision, and then we cover the rest of the patient with larger drapes. And now most of them are tailored to meet those specific types of surgeries that we're doing, whether it be on the abdomen, on an arm, on the head, anything like that.
When an extremity is to be prepped, an assistant should don sterile gloves and elevate the extremity so that it may be prepped around its entire circumference. For leg preps, an assistant holds the affected leg steady during the prepping procedure to avoid dislocation of the patient's hip and to prevent other injuries to the patient. A moisture-proof pad should be placed under the extremity to collect excess solution and prevent it from dampening areas where the patient's skin may come into contact with it.
Begin by positioning the patient. Use an assistant to hold the affected limb during the prep, or place the leg on a prep bar. Place a towel or chucks on the floor to absorb any excess prep fluid. Next, don sterile gloves using open glove technique and place sterile towels around the operative site. With the sterile gloved hand, firmly hit the back of the tube of the prep, then squeeze it until the prep solution is visible on the sponge. Apply the prep using circular motion starting at the incision site and widening toward the outer edges. Only one application is needed. Do not go back over prepped areas.
For prep of the leg or legs, the leg is prepped around the entire circumference from the toes to the waist level. The general boundaries for hip preps are abdomen on affected side, entire leg and foot, buttocks to the table line, groin, and pubis.
Prepping an extremity can be difficult because you got to get the whole way around and you can only see certain areas unless you're constantly moving to the other side, and having other people watching will help you to see from behind an elbow, behind a knee, behind a shoulder, things that you can't exactly see if you're standing on one side of the patient.
Draping an extremity provides 3 unique problems not faced in the first 2 draping scenarios. The body part to be draped for surgery is cylindrical in shape. Because the cylindrical shape requires a non-sterile team member to hold the extremity while the skin is being prepped, the extremity must be received from the non-sterile team member. Typically, the non-sterile team member wearing sterile gloves will be holding the extremity in an elevated position at approximately a 45-degree angle.
Place a down sheet under the operative limb. Another sterile team member grasps the foot with the stockinette and pulls it over the end of the extremity. Remove the adhesive portion of the U-drape. The U-drape is first placed on the undersurface of the affected extremity. The U-drape is then wrapped and sealed around the extremity. Coban is wrapped around the extremity starting distally and proceeding to just below the operative site. Place the extremity drape over the limb with the stockinette. It may be necessary to move to the opposite side of the operating table to facilitate placement of the extremity sheet. Take care to keep sterile gloves cuffed while unfolding the drape.
Draping, the most errors you see is people not covering their hands, the cuffing of the drapes. They'll breach and touch the patient's skin where it's not prepped, or they'll touch something else that's not a prepped area, so that totally contaminates their hands as well as the drape.
When prepping an arm or shoulder, the arm must be elevated by an OR team member. The arm is held by the hand so that the entire circumference may be prepped.
Begin by positioning the patient. Place an impervious U-drape around the operative site, taking care not to cover the operative site. Then place a towel or chucks on the floor to absorb any excess prep fluids that may drip onto the floor. Next, don sterile gloves using open glove technique and place sterile towels appropriately around the operative site. With a sterile gloved hand, put the sponge in antiseptic solution. Use circular motion starting at the incision site and circumferentially prep the extremity. Care must be given to ensure no small areas are missed and that the required boundary is prepped. Discard sponges after each single use. Repeat this process for a minimum of 5 minutes or until the counted number of sterile sponges have been used. Continue by blotting the area of excess solution and applying paint solution in the same manner as the scrub solution, taking care not to reuse the brush or retrace over any painted areas. Finally, remove the sterile towels in a safe manner.
The general boundaries for shoulder procedures include the base of the neck, shoulder, scapula, chest to midline, and circumference of upper arm down to the elbow.
Sterile team members place a down sheet lengthwise over the patient's body. Four sterile towels are placed around the operative site and are secured with towel clips. One sterile team member grabs the patient's forearm just below the prep. Another sterile team member grabs the limb with a stockinette and pulls it over the end of the extremity. While the first sterile team member continues to hold the arm with the sterile towel. The second sterile team member wraps Coban around the extremity starting at the distal end and proceeding to just below the operative site. The adhesive portion of the U-drape is removed. The first split, or U-drape, is placed on the axilla of the affected limb with tails going toward the head. The second split, or U-drape, is carefully placed starting at the superior portion of the shoulder with tails going towards the feet. Care is taken to keep sterile gloves cuffed while unfolding the drape. For prepping an arm or wrist, begin again by positioning the patient. If an assistant is used, the assistant grabs the prepped extremity with sterile gloves. Using a circular motion, begin prepping at the incision site and circumferentially prep the extremity. Do not miss an area of the skin. Discard sponges after each single use. Repeat this process for a minimum of 5 minutes or until the counted number of prepared sponges have been used. When using a two-step method, repeat this process. Finally, blot the area of excess solution and remove sterile towels in a safe manner.
The general boundaries for hand procedures are 3 inches above the elbow. For arm procedures, they are the entire arm, shoulder and axilla, including the hand.
Place a down sheet under the operative limb. Place a folded sterile towel just below the tourniquet and secure with a towel clip. Place the extremity or split drape over the limb with the stockinette. Make sure to keep sterile gloves cuffed while unfolding the drape. When applying the extremity drape, keep hands protected by the drape cuff. Grasp the patient's hand and slide the drape over the limb. Unfold the drape over the armboard and extend the body portion over the patient, making sure to keep your gloves protected with a cuff.
One common error for draping the patient is the drape will touch an unprepped area before being placed on the patient, which will have to be thrown away. If a surgeon compromises or contaminates the field in any way during draping, the surg tech will speak up. It is her duty and responsibility when the sterile field is compromised in any way, because it will compromise the patient's outcome.
For combined abdominoperineal operations, 2 separate prep sets should be used, one for the abdominal area and one for the perineal area. Sterile gloves should be changed between areas. For the vaginal prep, forceps will be necessary for the internal portion of the prep. Disposable pre-packaged vaginal prep trays are available. A leak-proof pad should be placed under the buttocks to absorb excess prep fluids. The following prep is used for hysterectomies. 2 different preps are used for this procedure, the abdominal and the vaginal prep.
Position the patient in the lithotomy position. place a towel or chucks on the floor to absorb any excess prep fluids. Don sterile gloves using the open glove technique and place sterile towels under the buttocks and at the sides of the abdomen. A one-person prep should start with the abdomen. Dip a sterile Q-tip in prep solution and remove debris from the umbilicus. With a sterile gloved hand, put the sponge in antiseptic solution. Using circular motion starting at the incision site, circumferentially prep the extremity. Discard sponges after each single use. Repeat this process for a minimum of 5 minutes or until the counted number of prepared sponges have been used. Begin the vaginal prep after the completion of the abdominal prep. Don sterile gloves using the open glove technique. Begin to use the second prep. Dip a sponge stick into the antiseptic solution. Prep the vagina first, and then the perineum, and finally the anus. Use sponges on sponge forceps to cleanse the vagina. Begin the perineal prep at the pubic area. Use a downward motion toward and over the genitalia and perineum. Discard each sponge stick after going over the anus. Do not reuse. Repeat the process. When prep is complete, remove towels aseptically as well as the chucks on the floor.
The general boundaries for vaginal and perineal procedures are the upper thighs, pubis, vulva, labia, perineum, and anus. Lithotomy draping is used for the following types of procedures: urological, gynecological, rectal, and general.
Begin by carefully cuffing your hands in the drape of the under buttock sheet and carefully place the sheet under the buttocks. Make sure to protect your sterile gown. Use towels and towel clips around operative site per surgeon request. Place leggings over the patient's legs. Keep hands in the cuff of the drape. Unfold the drape as you place it over the leg. Do not drop the drape or contaminate the sterile gown. Drape the opposite leg in the same fashion. Place the lithotomy drape. The lithotomy drape has a fenestration for the perineum. The perineum and legs should be draped first. The abdomen and upper body are draped with the remaining drape. Tip: draping the perineum runs an unusually high risk of glove contamination. Therefore, double gloving is recommended.
There are certain procedures where instead of having the patient in the candy cane stirrups, they're in Allen stirrups where their legs are a lot lower towards the floor. And a part of the Allen stirrup has a bar that comes out the bottom. And they still have to put leggings, the big drapes, over those legs in the stirrups. And the bar can be very difficult to get the drape around because as soon as they go over the foot, they get like between the stirrup and the bar, and it just contaminates the drape, and you have to, reposition it and redo it.
Performing the surgical skin prep and draping the patient are important responsibilities of the surgical technologist. By learning the proper technique and performing these procedures correctly, the surgical technologist can find satisfaction in their work by contributing to the well-being of the patient and being a significant member of the surgical team.
Okay. All right. I hope that wraps everything up for you guys. I know it's a lot of material, but just go through it, compare the notes in your book and your homework and the MindTap information with the lecture. Let me know if you have questions about this. I'll get this uploaded as soon as possible. And good luck studying. It's a lot of great material. It's going to make you a great tech. Thanks.